everyone for the invitation again. So this is the follow-up of the dynamic test that we went through a few months ago. And because this is for case discussion, the value of today's session really is for everyone to ask questions, interact, and feel free to query, because not everyone will do things the same way. And it's only through discussion that we can work out what the deficits are in certain dynamic tests, and the difficulties we have with interpretation. And Pearline, if I miss any question, do just let me know while I go through the slide. So without further ado, our first case is for investigation of low blood glucose. These are in fact all cases that I have to comment on in the last month. So they're all very recent cases. So this is a 30-year-old male nurse who presented with 12 months of symptomatic hypoglycemia that meets the criteria for Whipple's triad, and has a past medical history of depression, is on treatment for his depression. So automatically, just because of the occupation, some of the audience might wonder about surreptitious hypoglycemia, which is something that, of course, need to be excluded. Now, I'm going to start asking question. What do you think is the first test we should do for this 30-year-old male nurse whose glucose, because he's a nurse, he has had the opportunity to do point of care glucose, and it has been in the mid to low twos. So feel free to unmute or feel free to type a question in terms of what do you think is the best first test for investigation of hypoglycemia. So some people might also be wondering, is this a fasting hypoglycemia, or whether this is a postprandial after food hypoglycemia, and it happened in both settings in him.
Yeah, I would, Sherry, this is Sam. I would want to confirm the low glucose in a neutral setting, and if the glucose is low, I'll check insulin and C-peptide at the same time.
Yeah. That's exactly right. So we try to capture the test, and so the treating endocrinologists try to capture a formal low blood glucose, firstly with a mixed meal test. Do you do mixed meal tests in Singapore, Pearline?
So I'm not sure about that. I don't think so.
Yeah.
Probably just glucose challenge.
So glucose challenge is certainly a lot easier from the laboratory point of view, because we can just do it as an outpatient. It's generally a longer than 2 hour. It's a 3 hours extended oral glucose tolerance test to additionally capture the insulin and C-peptide pattern. The charm of the mixed meal test is if the patients say this particular meal always make my sugar go low, then we would use that meal. We also have a dietitian who would have a set protocol for a generic meal with a set proportion of carbohydrate, fat, and protein in an attempt to trigger a hypo. So as you can see, the glucose did not go low with the mixed meal test, and the mixed meal test does extend to 5 hours, so it is somewhat a tedious test, and you have to have a really good history that a certain meal trigger off the hypo. But importantly, we can get an idea of the first phase insulin response in this patient. So you can see that the fasting insulin before the mixed meal was given at 7:30 it was not particularly high. You can argue some people with insulin resistance are more prone to reactive hypoglycemia, so low sugar after ingestion of high carbohydrate load. That's not the case with the fasting insulin, and also the post-mixed meal response with the insulin is not particularly high. So we do see patient who is quite insulin resistant and their insulin go above 70 international units per litre, and their lowest or the nadir glucose was 4.1. So it's a negative mixed meal test. So the patient then proceeded to a 72-hour fast. How often do you do 72-hour fast? So I can see someone also is Dr. Shagana said ultrasound abdominal or CT. So certainly that would be the case once we confirm endogenous hyperinsulinemia that's inappropriate. We do have an extensive protocol for imaging. So 72-hour fast needs to be in a hospital setting is quite a tedious test. We have to train our registrar as well as the nursing staff in order to not miss the test. So I have highlighted here the glucose, the insulin, the C-peptide. I've already put in the cutoff for a abnormal low, inappropriately high insulin and C-peptide as per the 72-hour fast protocol. So this patient has been symptomatic from 40 hours onwards, and you can see that at 51 hours, the glucose dropped to 2.9. However, the termination of the test is when a laboratory glucose is less than 2.5. Now, if anyone has a different cutoff in the laboratory, do jump in and type a message. I'm also interested to know whether your laboratory would terminate a 72-hour fast based on a blood gas glucose, as some laboratory feel that their blood gas analyzer glucose do have quite a good low-end sensitivity and accuracy, and it allows the patient and nursing staff to terminate the fast a bit earlier. So regardless, while we go back to the patient, the glucose was 2.9 and the fast continued because we did not hit a target of 2.5. And you can see that later on or lower on the screen, the patient did hit a glucose of 2.2. So that qualifies for the termination of the fast because the patient has been symptomatic throughout. But unfortunately, no insulin or C-peptide was taken at the critical point when we have our glucose nadir. And that is not infrequent, actually. So the fast was terminated after confirmation that a less than 2.5 glucose has been reached. And after termination of the fast, the patient was given glucagon. Do you use glucagon in your laboratory? Anyone? At the termination of the fast? So some laboratory would use glucagon to further confirm the effect of endogenous hyperinsulinemia, because when there is insulin excess, which is an anabolic hormone, then there will be large glycogen storage in the liver. And after giving glucagon, we do expect at least a 1.4 millimole per litre rise in glucose, if that is the case. So it is a secondary endpoint, if you like. So what do people think of the 72-hour fast so far, you have, we did have a low glucose, less than 3, that had an inappropriately high insulin and C-peptide. However, without any intervention, the glucose then hovered. So without feeding the patient, the glucose went up a little bit, up to 3.2, and then went down to a nadir of 2.2. We don't know what happened to insulin and C-peptide then. Once again, without feeding, the glucose actually recovered up to 3.2. At that stage, the insulin and C-peptide were both appropriate. And I should also add that at the termination of the fast, we always do a beta-hydroxybutyrate for ketone. Once again, in the setting of insulin excess, such as insulinoma, there should be an inhibition of ketone. And this patient actually does have a higher than expected level of ketone. So how would you report this 72-hour fast? Would you say is a positive or abnormal 72-hour fast because of the inappropriate insulin and C-peptide? Would you call it inconclusive because despite the inappropriate insulin and C-peptide, we also have an inappropriate beta-hydroxybutyrate is a little bit too high for someone with insulinoma. And also, after giving glucagon, there was a lack of a rise in glucose to reflect insulin excess associated glycogen storage in the liver.
Sherry, can you exclude exogenous insulin before 60 minutes? So the 62-minute insulin is 1.8. Does it exclude? I mean, are we suspecting the patient's taking insulin by himself or herself? Is it a man?
Not, yeah, that's a very good question because remember this is a nurse, and it's because the C-peptide is still inappropriately high. So for people on surreptitious insulin, then we don't get a high C-peptide. We can have variable effect on insulin. As all of you are aware, the synthetic insulin have differential cross-reactivity with different immunoassay, and so the Abbott architect tend to recover synthetic insulin, and we usually can pick that up because not only do you have a low glucose, you have a very non-physiologically high insulin in the hundreds, whereas the Roche insulin assay do not tend to pick up the synthetic insulin, and you tend to have a very low or undetectable result. So yes, we need to exclude surreptitious insulin, and of course, if the patient's taking sulfonylurea, then both insulin and C-peptide would be inappropriately high. And we do a sulfonylurea screen, which in this patient is negative. And we also do an insulin antibody to ensure there's no interaction or interference with our insulin assay. So we have had a few cases of Hirata syndrome, which is autoimmune hypoglycemia due to a high insulin antibody. So no one has typed in any notes about how they would like to interpret this report. So I'll move on to my interpretation slide. So for the diagnosis of inappropriate endogenous hyperinsulinemia, we need a low glucose, and we've got that in this 72-hour fast. We need a inappropriately high insulin and C-peptide, and we both got that in the 72-hour fast. The proinsulin, you might have noticed in the right column, was not high, and we only send off the proinsulin if the patient achieve a low glucose in a 72-hour fast, because otherwise it's not necessary. So that is contrary to our biochemical diagnosis of inappropriate endogenous hyperinsulinemia. And the beta hydroxybutyrate I've shown you was also inappropriate, and the glucose did not go up after glucagon injection. So overall, this was an abnormal 72-hour fast, but did not fulfill all the criteria for endogenous hyperinsulinemia. And so it is in the gray zone. And the clinician have, so one of you have already mentioned imaging. We try to avoid imaging until we have a biochemical diagnosis, because as people get older, we do get incidentaloma. But the clinician has elected to do a GLP-1 nuclear medicine scan, and it is a scan that generally will result in generalized uptake in the pancreas, particularly in the nocidioblastosis. In the post-gastric bypass, hypoglycemia, some of these patients also get islet cell hyperplasia, so they behave like a nocidioblastosis. So any question about the low sugar investigation? So if not, we're going to move track now, and we're going to talk about high blood pressure for investigation. So this is a 40-year-old female who had preeclampsia during her pregnancy, but after delivery, her blood pressure persists to be high, and she remained on 2 blood pressure tablets, monocidine and verapamil, and she had an elevated aldosterone renin ratio. Her potassium remained normal. So due to her age, as well as the fact that it's unusual at her age to require 2 agents to control blood pressure and the abnormal ARR as a screening test, she proceeded to a saline suppression test. And in Royal Melbourne Hospital, we do seated saline suppression tests. Some institutions choose to do supine saline suppression tests. So the difference is when you are lying flat for 4 hours with 2 liters of normal saline in, generally you would want to go to the toilet fairly much straight away at the conclusion of the test, and that postural change can sometimes change the aldosterone. So the seated test has been investigated by Michael Storwayson group and found to have a better predictability. The cutoffs are different for seated saline suppression tests, and so I've shown you here the aldosterone. We do aldosterone on the liaison immunoassay in-house, and that's at baseline. That's 4 hours later at the conclusion of the test. On the aldosterone immunoassay, the cutoff for a abnormal or non-suppressed aldosterone is 220, as you can see below. So this patient did not have sample sent for mass spec aldosterone. The cortisol was done to ensure there's no ACTH driven effect, and you can see that the cortisol went up at the conclusion of the test. So we cannot exclude a stress effect, an ACTH-driven aldosterone that could have falsely taken the completion aldosterone up as well. So that's a cross because it's clouding our interpretation of the test. And the potassium. So with the protocol, the potassium is meant to be maintained about above 4. And at the conclusion of the test, it was 3.8. So a low potassium can falsely lower aldosterone. So we have 2 parameters that's clouding our interpretation. We routinely ask for all of these parameters so that we can interpret at the end. So the renin doesn't play a role, but sometimes if the renin was aldosterone ratio was done outside of our laboratory. We just want to confirm that the ARR is abnormal at baseline, and the sodium is in case there is any contamination from the saline infusion. Still, we do a full UNE at the baseline as well as completion. So this is the result for this 40-year-old lady, persistent hypertension. Any thoughts? Would you call this a positive test, i.e. suggestive of primary hyperaldosteronism, despite the two issues here? Any thoughts on how you might want to interpret this result? So if there are no thoughts, I'll move on to let you know. So the clinician saw that, and despite all the disclaimers here, felt that, well, it's above 220. So this is the confirmation test for primary hyperaldosteronism, and the clinician referred this patient on to and I should also mention the adrenal imaging was completely normal as well. The clinician referred the patient onto the adrenal venous sampling to localize the side of the aldosterone, apparent aldosterone excess. So although there's a lot of numbers in the test, all you need to know is before senexin, after senexin, there's the right adrenal, left adrenal, peripheral. And in essence, our clinician only need to look at the table below because it does all the calculation for them and tell them about the ratio. So firstly, the adrenal vein to peripheral cortisol to prove. So thank you. Someone agreed this was an inconclusive saline suppression test. I also agree with that, but we couldn't stop the clinician to proceed to the adrenal venous sampling. So the adrenal vein, both right and left, were successfully cannulated because the adrenal vein to peripheral cortisol ratio were elevated. So greater than 2 in every single sample, whether it's right or left. So successful adrenal vein cannulation means that we can then interpret the ratio of the adrenal vein AB aldosterone cortisol ratio. So the calculations are already there for you. 3 is the cutoff. So if you have a ratio 3 and or above, then it means that there's evidence of lateralization. So 4 means that there is quite good evidence of lateralization. And as you can see here, whether you look at the pre or the post duplicate sample, none of the ratio, the lateralizing ratio were all below 2. So no lateralization here. Patients reassured that there is there's no evidence of lateralization. The problem somewhat is when you get to this stage, you are assuming that there was hyperaldosteronism. So if the saline suppression test was inconclusive and you proceed to this, it becomes really, really difficult because even if you lateralize and you look back at your result, you end up having an inconclusive saline suppression test, a maybe lateralized to one adrenal gland. So does that mean you would actually go and take an adrenal out when the CT imaging is normal? So which is why dynamic test is really a stepwise process. If you move through the test without passing each station, it gets really difficult in terms of decision at the end of the test. Now, so if there are no questions about that case, I just want to highlight the difference, I suppose, in terms of immunoassay aldosterone and LCMS aldosterone. So we all know that immunoassay are less specific for the analyte. There are certain cross-reactivity, and in the suppression test, we are looking at the immunoassay can cross-react with downstream metabolites, and we all know that LCMS generally read lower, and we try to cater for that in the cutoff because the LCMS cutoff aldosterone is lower compared to the liaison immunoassay. However, is it low enough? And that is always a very difficult question. So Moe explored whether the theta saline suppression tests looking at the LCMS cutoff as well as a diazorin liaison, what is the area under the curve, and they found that at the 4-hour aldosterone mark, around the 220 is probably going to give you the best diagnostic accuracy, and that's what they publish also in their paper. However, in practice, I do find that quite a few patients go over the 220 mark on the liaison aldosterone assay, and they have a clearly normal mass spec aldosterone. So I believe this might be an example. So 40-year-old male, 2 years of high blood pressure on monocidine, but also on amlodipine. Now, of course, the AR ratio is elevated. Amlodipine, as we know, can interfere with the renin-aldosterone ratio, and we generally ask the clinician to put the patient on appropriate medication before any dynamic testing. However, this chap was still on the amlodipine at the time of the theta saline suppression test. So in terms of interpretation of the result, the calcium channel blocker can reduce aldosterone, and I should also mention with the previous lady, estrogen can also cloud the interpretation of the test, particularly the ARR, because the direct renin assay on women taking oral estrogen, which stimulate the production of the renin substrate, can give you a low direct renin. But if you use plasma renin activity in your lab, then it's apparently raised. So you get a sometimes confusing picture if patients are on the oral contraceptive pill. So that aside, back to our 40-year-old man who had high blood pressure for 2 years on amlodipine, a calcium channel, fast-acting calcium channel blocker, and these are his results. So I've already put in the tick to say that if you look at the liaison assay alone, then yes, his completion aldosterone was greater than 220 picomoles per liter. Therefore, it's a positive saline suppression test. But the same sample sent to mass spec laboratory was below the 140 cutoff, which give us a discrepant result. And because I'm seeing quite a lot of this a bit high but not very high liaison aldosterone at the completion, now we routinely send an aliquot to LCMS aldosterone as well to get more information. So the cortisol was fine, so there was no ACTH-driven high cortisol to interfere with the aldosterone. The potassium, however, so once again, this patient was inadequately prepared in the sense that the potassium at baseline was already low, and a low potassium can lower your aldosterone. The amlodipine can also lower your aldosterone. So if those two factors were not in place, would the mass spec aldosterone have been higher? We don't know. So the comment for this case is a non-diagnostic test because both the low potassium and amlodipine should have been addressed prior to booking the patient for the tests. So one of our clinicians complained to me that, well, Sheree, the potassium in a private laboratory outside of the hospital was 4.2. But when the patient come to the hospital laboratory, it was 3.8. So is there something wrong with the hospital laboratory? And in truth, it is to do, as we all know, there is more delay in sample separation or centrifugation in the community collection because there is a sample delay, and generally they do have slightly high potassium. So I'll move on to my last case. Because so far I've been showing you saline suppression test that's a bit indeterminate, and this is to showcase someone who has a pretty high pretest probability. So a 65-year-old male who's had high blood pressure for 15 years, also have type 2 diabetes, have obstructive sleep apnea, so quite a few risk factors for having high blood pressure anyway, but had persistent high blood pressure on 2 agent, and more importantly, potassium has been low and needed clofazine 2 a day to correct, and the ARR was elevated. So he proceeded to have his saline suppression test. I also want to emphasize his adrenal looked normal on imaging. So moving to the aldosterone assay, immunoassay, it was above 220, clearly above 220 in this case, so abnormal. The cortisol went down, not up, so did not interfere with aldosterone interpretation. The potassium, despite the clofazine, was low and went lower. However, seeing that the aldosterone was clearly high, having a potassium that might have falsely lowered the aldosterone would not have interfered with our interpretation. So this is a chap who has likely primary hyperaldosteronism, confirmed on the saline suppression test. He did proceed to the adrenal venous sampling for localization. Once again, just concentrating on the calculation, the last 2 lines, the adrenal vein to peripheral cortisol ratio, clearly high, clearly cannulated, both sides, right and left, and the lateralizing ratio. So a ratio of 23, so that's clearly above 3. And now, if we look in more detail, so lateralizes to the right with a high lateralizing ratio. If we look in detail just at the pre-synaptin or baseline, you can see the right adrenal vein ACR4, and the apparent unaffected side had an ACR of 0.2, which was lower compared to the ACR of the periphery. So once again, this is a secondary endpoint. It helps us confirm that the right abnormal because of the quite high lateralizing ratio. The unaffected gland is suppressed to the periphery, which would also suggest that the right side or the affected gland is the side producing the excess aldosterone. So with that clear lateralization to the right, despite a normal adrenal CT, the patient proceeded to have a right adrenalectomy. So under the posterior approach, and this histology report only came into my mailbox 2 days ago, so it's quite a fresh case. They did find a 1 centimeter right adrenal adenoma that is suggestive of con, and of course, after the adrenalectomy without potassium supplementation, the potassium is now 5.4. Just to reflect on the fact that on 2 clofazine a day, previously the patient's potassium was still 3.4. The patient remained on 2 blood pressure agent at the moment. a lot of the patient who's had primary hyperaldosteronism for many years, as is the case in him, we correct the potassium. We don't always normalize the blood pressure. Generally, the blood pressure improves, but because the vasculature would have had changes after the many years of high blood pressure, so even though you have a surgical cure of the problem, the blood pressure might persist to need medication. So this is a cons of primary hyperaldosteronism with a full hand. So tick all the boxes, proceeded without the requirement for abnormal radiology, and achieve the outcome as predicted. Any question about blood pressure investigation for hyperaldosteronism? So if not, I'll move to Cushing investigation. So this is a 70-year-old female referred because of a cystic pituitary adenoma, some facial redness, overweight, not obese, and the 24-hour urinary free cortisol was normal. But the 1 milligram dexamethasone suppression test was not fully suppressed, so it was greater than 50 nanomoles per liter. So as you know, there is a gray zone for the 1 milligram dexamethasone suppression test, and most lab would report 50 to about 110 as a gray zone. So if this falls into the gray zone, possibilities are a very mild early Cushing given an adenoma that's already present, or this could be pseudo Cushing in someone who's a bit overweight and or depressed. So to differentiate a true Cushing from pseudo Cushing, the patient proceeded to have a dexamethasone CRH test, and this is just a protocol to remind you that it involves 0.5 milligram of dexamethasone every 6 hours for 8 doses. And then the patient come in for baseline test, given an injection of CRH, and then 15 minutes later have a cortisol. So we end up having 2 cortisol results to interrogate this patient's pituitary adrenal axis. So the day 0 before dexamethasone, and you can see the patient went to 2 different labs, the hospital lab as well as a community lab, and I put both there because the ACTH are on different assays, Siemens and Roche. Imulite and Roche, I think, and therefore a different reference interval and different reporting units as well. That aside, ACTH does not come into the interpretation of the Dex-CRH test. It's only if the Dex-CRH test is abnormal, then we go back to the ACTH. The cortisol on day 0 was 365 after 8 doses of 0.5 milligram dexamethasone. Cortisol was suppressed down to 22 nanomoles per liter. And so that is a tick for the interpretation because we need the post-dexamethasone less than 38 nanomoles per liter. And furthermore, after CRH stimulation, the cortisol failed to go above 38. So it is normal on both counts, and we can reassure the patient and clinician the test indicates a pseudo Cushing, or it can be a normal result. So I think this might be my last case. This is secondary hypocortisolism for investigation. It is a 30-year-old female with headache, dizziness, amenorrhea, had a macroadenoma in the pituitary that was resected, and after resection, the morning cortisol was 130 nanomoles per liter, noting that before the operation, the patient was given hydrocortisone support given the non-reassuring morning cortisol previously. So the clinician is asking, shortly after a transsphenoidal surgery of this large adenoma resection, whether the patient still need hydrocortisone. And patient went to have the insulin tolerance test. Given there's a high probability of hypopituitarism, the patient was given 0.1 unit per kilogram of insulin as the hypoglycemic dose. And this is the general procedure. I would just want to highlight the procedure because although the insulin is given here after the 0-minute blood test, some of the hospital registrar would terminate the test the moment the patient has a low glucose, and they immediately collect, and then they terminate the test. And I emphasize to them that this is not a 72-hour fast, so we're interested in capturing all the sample, but the key sample is actually not the low glucose sample, because the low glucose sample just indicate that's the start of the stress to stress the pituitary. Therefore, we are interested, just like a short synaptin test, we're interested in the 60 minutes after the hypoglycemic episode. So the result, the glucose went down appropriately within half an hour. If the dosing of the insulin was correct, the patient should hypo within the first 30 minutes. If it is incorrect, if they gave a low dose of insulin in someone who's overweight, who's got diabetes, you end up protracting the test, because the patient might feel a little bit unwell, but they never hit the 2.2, and then you're obligated to give another dose of insulin. So the choice of the dose of insulin at 0 minute is very important. So we achieved the 2.2. That's adequate hypoglycemia. And as you can see, that the cortisol continued to go up after that stressful event. This is as expected, because we are doing the collection to look at the cortisol peak. And you can also appreciate that in our institution, we aim for a cortisol of at least 500 nanomoles per liter. That is, of course, assay dependent. And we easily achieve that within 10 minutes of the adequate hypoglycemia. A lot of the time, the clinician want to look at growth hormone, because although the test is primarily looking at cortisol, growth hormone will also be stimulated as a stress response. And the growth hormone peak clearly shows that the patient is not growth hormone deficient, is certainly adequate. So the comment for the insulin tolerance test is that consistent with normal cortisol and growth hormone response in response to stress. So that is really my last slide, and you might notice this is the same slide I use for the conclusion, because case studies as well as a protocol all have the same issues. So I'm going to stop here if there's any question. And I'll stop sharing my...
Very quickly, the 500 cortisol 500, is that by which assay is that?
So that's the Abbott architect. You can argue it can be a bit lower to 470 nanomoles per liter, but our clinician have voted to have a 500 nanomoles per liter. And so some institution with mass spec assay, their cortisol target or peak is a lot lower at 450 nanomoles per liter.
Yeah. So is that the same cutoff for selectin test?
It is. It is. So we both cutoff is targeting what is an appropriate stress response. So certainly within an institution, you should have the same cutoff for short synaptin as well as the ITT.
Okay, I don't want to monopolize, but a very quick question. I had to go away for a short time. I had to attend something, but discrepancy in the aldosterone levels between immunoassay and LCMS. What sort of correlation do you find with the regression line? We found a lot lower aldosterone by LC mass spec, and the cutoffs don't seem to match the discrepancy between the assays. What do you see? I think you showed the results.
Yeah, I completely agree. And I feel that currently, certainly in Australia, and probably overseas, not a lot of lab have access to the LCMS assay, which would be ideal, is most specific. I find that there is quite a large discrepancy between immunoassay and the LCSA, not so much at baseline, but at the 4-hour mark after saline suppression. It's patient dependent, and it's probably dependent on what sort of downstream metabolite the patient is making to cause this discrepancy. And I find that the current published cutoff for the liaison immunoassay is not ideal. I find it should be a bit higher. So I think this is an area in need of more work as well.
Okay, thank you.
So then, Dr. Chung, what do you propose or recommend for institutions that don't have access to LCMS?
So for us, we send our LCMS aldosterone to Queensland, which is where the publication for the aldosterone immunoassay 220 was originally done in Michael Stowace's group. And so although there is a delayed turnaround time because of the interstate transport, I feel that I'm more confident in interpreting the result, particularly for the borderline cases where the pretest probability is a bit low. It just crossed over the 220 mark. And having an LCMS that's truly normal, I find it reassuring to not proceed further to adrenal venous sampling. Sam, what do you do? Because you've looked at your correlation, and what do you do with your aldosterone?
Yeah, well, we have transitioned to seated saline suppression test. We are still using the liaison cutoff. So we certainly use 170, and yeah, possibly 220 as the higher cutoff. We are measuring the LC-mass spec aldosterone, but not reporting them because of the lower values, and we don't know what the appropriate cutoff is. So we're still trying to find our way through the LC-mass spec assay. So it's just the liaison, and we follow your harmonized protocol and cutoffs. Yeah.
So I'm ashamed to say, even though we wrote the harmonization program and look at all the data, I find the cutoff of 220 that's published by the Queensland group still a little bit woolly. Yeah, it would be really great actually if we share data, because Greg also did some correlation. He also feels that 220 is a little bit low, but that's what their publication with limited number is. Because the problem is more and more there is a push to screen patient for primary hyperaldosteronism. So more and more we're not getting the florid cases. We're not getting those obvious, very low potassium, definitely a primary hyperaldosteronism. With the borderline cases, it's very important to not over-diagnose and over-investigate.
Yeah, agree.
So, are there any other questions or query or things that you might do differently in your lab with the dynamic test?
There is a comment about the borderline zone, maybe due to ACTH-driven effect. One of the delegates has asked.
Yeah. So we certainly take that into account. So although we can try to control potassium, and I also thought about whether we should get the baseline VBG potassium. So if it's already low, we can give some oral replacement straight away so we don't run into the problem of interpretation at the 4-hour mark. The cortisol we can't change. I have to say most of the time the cortisol goes down because the patients get a bit bored after seating for 4 hours, and we don't really get cortisol going up. There's the occasional patient, for whatever reason, they get really stressed out with being hooked to a drip in a chair.
Yeah, I've got a couple other questions, but I don't want to monopolize the talk. If someone else has questions, maybe I'll ask one more. So with the adrenal vein sampling, we don't routinely do synectin stimulation. Do you do them on all your patients?
We do that on all our patients because until recently, we don't have a high successful cannulation rate. So synectin is only useful for places where you don't have a dedicated radiologist who's very good. So if in fact your radiologists only have a successful cannulation rate of 40%, so that's less than flipping a coin, then using synectin will raise that, will increase your probability of getting a successful cannulation. So I have to admit, now that we have Alex, who's very good, we almost don't need the synectin.
Okay. Yeah, we do point of care cortisol. It's a semi-quantitative assay, but can very quickly confirm cannulation by a point of care cortisol, which is what we do, and our cannulation success rate has gone up quite significantly since we do that. I mean, we had 2 dedicated radiologists who are good, but they got even better results with point of care cortisol to confirm cannulation.
Yeah, that's good. We also considered that, but as we were contemplating, they got better at it and then they didn't want it. Yeah.
Sherry, can I ask a question? How does the biological variation of aldosterone affect the aldosterone renin ratio in screening and then in the confirmatory tests? Are there any data on biological variation of aldosterone, how it influences the interpretation?
Yeah, so no data on healthy biological variation per se, because as you know, the ARR differs with SA. So in Australia, I think most of the laboratories are now moving to liaison aldosterone and liaison renin. And even with the liaison, we do sometimes get lot-to-lot variability. So biological variation is assuming that there is no age difference, there's no renal impairment difference, and in premenopausal age women, they don't have variation in their estrogen level. And of course, none of those assumptions are true, because as we know, the renin and aldo do go down with age, and with renal impairment, it can also alter the result. So I think it's really difficult to get true data on biological variation when the population we're doing the tests on are the older patients. So they're not often healthy, they often have high blood pressure for a while, and they often do not have perfect EGFR either. But I appreciate it is very difficult, which is why it's a soft screening test, and then you try to remove all the medication. For women on the oral contraceptive pill, you need to think a little bit harder, and then when you have a high enough pretest probability and the ARR is abnormal, you do then need to move on to the confirmation saline suppression test.
Thank you.
Thanks, Kay.
Thank you for your excellent presentation. Is there a place in a mixed meal test in a patient with diabetes who frequently get hypoglycemia?
Well, it's a little bit difficult to interpret glucose in someone who's already on diabetic medication. So it depends on what stage of diabetes. Certainly in patients who have pre-diabetes and you are trying to have a diagnosis of reactive hypoglycemia, you can still do that because they'll still hypo. But then if you have a patient on insulin with low sugar, then it is actually going to be a different investigation path, because then you need to exclude, is it the insulin? Is it the insulin antibody? And it gets a bit more complex.
Thank you.
How easy is it to get CRH, Sherry?
We need to book it with pharmacy. And in fact, today we had inferior sinus sampling where the CRH arrived, but the solvent to dissolve the CRH in did not arrive with the CRH, and there was a bit of a kerfuffle about what to use to dissolve the CRH. So it's not something that we have in the pharmacy every day. We do need to pre-order it in, but otherwise we don't have any issue. Do you have issues, Sam?
Yeah, I'm not directly involved anymore. It's the registrar who organizes it, the endocrine registrar. We used to have to get TGA approval or something like that. I presume it's now approved for.
Yeah, I'm not sure what paperwork they need to fill out, but yeah, the registrar have to do all the legwork beforehand.
Yeah, we also had trouble with the sulfonylurea test, which used to be available in Perth, but not anymore. We have to send it away, so it takes a long time. It goes to Sydney, I think, or Adelaide, I've forgotten.
Oh, okay. We do it in-house in Royal Melbourne. Yeah, and our turnaround time is okay, I think.
Yeah,
so there was a question from Diana. I didn't quite catch your point about stimulation tests across reacting with upstream metabolite and vice versa. So Diana, that was the stimulation test would be the short synaptin test. And so in short synaptin test, the cortisol at 30-60 minutes, the peak cortisol differs quite a lot between different immunoassay, and that would be due to the differential cross-reactivity with cortisol. And similarly with suppression tests with aldosterone, in this case, it is about the cross-reactivity with the downstream metabolite. So as you suppress aldosterone, but everything downstream is already made, it is already there. And people who work in pediatric hospital would notice that when you have a neonate with CAH or query CAH and you do the aldosterone, sometimes it's on the immunoassay, it's a lot higher than what should be the case clinically. And then when you enter the mass spec assay, it is more appropriate, and it's really just the cross-reactivity with the aldosterone immunoassay, which in truth was not marketed for dynamic tests. They're really just using it to look at aldosterone by itself. So I hope that answered your question. Thank you, Diana. So we're drawing on to 7 o'clock. So if there's no further question, Pearlie and Sam, shall we draw the meeting to a close?
Yes, so thank you very much, Dr. Chang, and thank you everyone for your support and your questions and this great discussion that we have.